Get started with this because I know this is early, and thank you everybody for joining on. And George is in California. Thank you for taking the time to do this and getting up really early. So we appreciate that. And Hal just joined, so I'm going to wait just a second until his audio and video comes in, so that there's Hal, so I can introduce Molly in just a minute. All right. Okay, Hal's in. Hi, Hal.
Hi.
All right, everybody. Welcome this morning. It's so nice to see all of you this early. And I wanted to, what I was going to do is in my little speech that I introduced when we introduced the doctor, I was going to start off by introducing Molly. And since Dr. Margolis isn't here yet, I think that I'll take this time to just introduce Molly right now before we start the whole thing up. Molly Peterson, wave, Molly.
Yeah. Oh, I'm sorry.
Molly Peterson is coming on to cure multiple myeloma.
I'm good. I'm good.
She's,
Thank you.
wait, hold on. Somebody's, she is coming on to do what I do, so I can retire. And we're so happy to have Molly. Molly is a multiple myeloma patient. Some of you might know her from from other groups. And so and Molly's a social worker, and she has a real passion for this, obviously, because of her connection with multiple myeloma. So we're really excited to have Molly here, and she's learning the ropes right now. And I think next time she's the one that's going to lead this, right?
Oh, okay. I'll be coming over early in the morning, Mickey.
Okay.
We'll do it together.
Okay. All right. So anyway, welcome, Molly. And we're so happy to have you. And it's been fun so far, teaching you some of the things that we do here. And I think it's going to work out really well.
Oh, thank you, Mickey. I appreciate that. I appreciate all your help.
Well, sure.
Yeah.
I'm going to give this stuff to you.
Yeah.
Good.
Yeah.
Good. So I still don't see Dr. Margolis, Sid. So what do you think I should do?
Why don't you start for him, and I have no idea.
I can text to Stacy, his assistant, and just see if he's coming on. But that's about all,
I'm sure one of us would have got a text if he wasn't. He had an emergency or something.
Okay, let me check my email just to see if there's something there. I don't have anything. Did you check yours?
Do it right now.
Okay. I don't have anything in my email that from Stacy or Dr. Margolis. So I'm just gonna email.
Do many of the people in this group also have amyloidosis? Or is it just multiple myeloma?
I don't know. There are people that have it as well, yeah, but I don't know the numbers.
Yeah, why don't we? Yeah, if you have a question for each other, let's take this time to do that until I see if Margolis is going to come on.
Does they usually do it at home? Or?
I don't know. What is it today?
Is amyloidosis.
My husband has both, and a lot of times they are at the same time. It's a misfolded protein that ends up accumulating in various organs. His happens to be his heart. And so he's kind of dealing with both things at the same time. But I was curious. I didn't know what percentage of the people, it doesn't sound like anyone else that maybe in this group has it.
I don't know.
Yeah.
How long has everybody had their disease?
My husband was June of 20, so it's been almost 2 years.
Okay.
Been about 2.5 for me.
About 2.5 for me then.
Yep, about 5 for me, a little over 5 years.
8 months.
Well, just,
Two and a
I've
half.
been 14 years. So,
My husband is 7 years.
okay.
Okay.
About 23,
You're 23?
Wow.
23 years.
Wow.
Good.
Well, good for
3 and
you.
a
How do you,
half for me.
Wow,
how do you
that's
feel?
awesome.
How do you feel?
Who, me?
Yeah. That's a long
Well,
time.
I got a lot of other problems now too. I see this bandage on my ear. I had melanoma on the top of my ear and had a piece of my ear removed to make sure they got it all.
Uh-huh.
And also recently diagnosed with prostate cancer. And I submitted a question about, when thalidomide came out, one of the reasons they tried it in the first place was the fact that it's anti-angiogenic, which means it prevents the formation of new blood vessels, and tumors need a blood supply in order to grow. And so it's not clear why it worked for multiple myeloma, but it should work for solid tumors, you would think, because, solid tumors need a blood supply.
Mhm.
But, I'm graduated from thalidomide to Revlimid to Pomalyst, and I don't understand how I could develop prostate cancer when I'm taking Pomalyst, because it should, I assume that it's an anti-angiogenic like thalidomide was. So that's the question I submitted for Dr. Margolis.
Is he your doctor?
No, I submitted it yesterday by email.
Oh, I'm just curious. Who do you see?
I see Dr. Zonder.
Okay. Sure.
And I'm trying to get him to talk to my urologist, because the urologist doesn't plan, because of my age, he doesn't plan to use radiation or surgery. He just wants to give me a drug to reduce my testosterone. He said I may have hot flashes, and my wife thought that was great. She said I deserved it, but anyway, I haven't started that therapy yet. But I submitted a question for Dr. Margolis about how we can develop these other cancers when we are on therapy for.
Good question. Are you still on Pomalyst now?
Pardon me?
Are you still on Pomalyst?
Yeah, I'm taking Pomalyst, Dara, Ninlaro, and Dex.
Wow.
Since those things reduce my white count, my neutrophils, I have to give myself shots to boost my white count every week. So,
Al, did you ever have a stem cell transplant?
yeah, back in 1999, I had a stem cell transplant, and I had about 2 years of remission. And then when I relapsed in 2001, there still wasn't anything new to treat multiple myeloma, except the University of Arkansas was doing a trial with 23 patients on thalidomide, and it worked for about half of them. And they didn't have any other, anything else to treat myeloma at the time. So even though it was only approved for treating leprosy, my oncologist prescribed thalidomide for me at that time, and it did work, but it gave me neuropathy. That was the main lasting side effect. I was on it off and on until 2003 when Revlimid was approved. And then I switched from thalidomide to Revlimid.
So the Revlimid worked until they put you on Pomalyst later?
Well, the Revlimid worked for a while, but it was causing my counts to drop too low. They kept reducing the Revlimid dosage, and because my platelets were getting below 100, getting down to 80 or 50. So, and I was down to 2.5 milligrams of Revlimid by that time, and it wasn't working anymore because of the low dosage. And so then I got referred from my Beaumont oncologist to Dr. Zonder at Carmanos, and he started me on elotuzumab, and that did not work. And we know it doesn't work by itself, but I was taking it as a single drug, and that didn't work. So then I went on a clinical trial for Kyprolis, Pomalyst, and Dex, and that was working until I got COVID in around Thanksgiving of 2 years ago, 2019.
Early.
And I barely survived COVID. Then remdesivir kicked in and started to turn the corner after the third day. I was in the hospital for 11 days, including Thanksgiving. Had lunch meat turkey for Thanksgiving. But after I pulled through the COVID, Dr. Zonder didn't want to put me back on Kyprolis because of my heart and lungs were still recuperating from the COVID. So I dropped out of that trial, and now I'm on this Dara, Ninlaro Dex. That's working. But like I said, I got these new problems too. I got the
Cancer.
Melanoma, yeah.
melanoma on my ear and prostate cancer.
Well, you're an inspiration to me. 23 years.
Yeah,
It's amazing.
That is amazing.
I like to be an inspiration.
Yeah.
I remember, I think I was about 3 years into my myeloma journey when I first met Jim Webb, and he was a 10-year survivor at the time.
Yeah.
So, I said, well, if he can do it, I can do it. And I want people to say that about me now. I want them to say 23 years? Well, if Hal can do it, I can do it.
You gotta be very lucky.
Hi, Mary. I see your picture.
Mary's just joining in, so I can't hear you quite yet. Takes a minute or so. Does anybody else want to say anything to the group here? We have some people here from our sponsors, Adaptive Biotechnologies and GSK. Anybody can feel free to say whatever they would like right now, our drug reps included. So, since we're waiting for Dr. Margolis, I did get a text back from Stacy, his assistant, saying that she was going to try and contact him and find out what the deal is. But I haven't heard back from her yet. So, so please use this time if anybody wants to say anything. We appreciate it. And I'm hoping, I'm hoping we'll get Dr. Margolis on here, but if not, we'll just wait till next week.
Is anybody going to Gilda's big night out tonight?
No. I didn't-
No, where is it?
It's at the Garden Theater in Detroit, and I'm not sure, the flyer for the big night out doesn't give an address, so I'm gonna have to look it up online. I don't know where the Garden Theater is.
Wow. You're
What
going
is
to
it?
go? Hal, you're going?
Yeah, I'm planning, wearing my mask. I've had my Evusheld shots. I've had 2 booster shots, so I guess I'm as protected as I can get. But I'll try to wear my mask most of the time.
Dr. Margolis, I'm sorry, Dr. Margolis's talk this morning was going to be about Evusheld and the importance of everybody having it. So sure, I'd like to hear that.
Right. Well, Dr. Pianco did mention it too, and with a specific regimen for the timing between your other shots. So this is kind of important to understand, because there's a difference between being protected and having it interfere with other medications and things. So
That would be interesting to know about. I've had Evusheld as well.
right.
Where did you have it at? The hospital?
I think I had it at St. Joseph's Hospital in Ann Arbor.
Okay.
I had it at Carmanos, and they didn't seem say there was any problem getting it at the same time I was getting my myeloma therapy.
It wasn't,
They-
I think it was,
I had myeloma therapy either.
yeah, it wasn't between the myeloma therapy and the shot. It was between the booster.
Right.
Oh.
And so if there was enough time between the boosters and the Evusheld, that was the timing that he was concerned with.
So I'm curious, were there any side effects with the Evusheld?
No,
No.
not for me.
No.
Zero.
No.
Zero. I think Dr. Margolis has some in his office. So you could ask him when he shows up, just call there, make an appointment and have the shot. But it's critical you do that. Everybody do it.
There's the last time that we were on, there was a website that we shared with everybody on the call that has a list of all the different locations that have it. I can actually send that out to everybody. All of you plus everyone else later on. It gives the location, so there might be a location near you that has it if you don't have it already. But it is, from what Dr. Pianco said, and it's just from listening, it's important to pace it between the booster shots. Because
In my experience, after my second booster shot, I found out about Evusheld from Dr. Zonder, and he recommended it for me. I had no side effects. It was a couple of shots, and I believe I got a lot of protection from it because I was in a gathering of people. Half of us got COVID, and I was among the half that did not. So
Wow.
I can recommend it.
Wow, that's
Good for you.
Yeah.
Well, Dr. Margolis is a big proponent of it. I know that. And I think it's critical, absolutely critical that we get it as soon as possible. Did you hear that, Molly?
Yeah, I heard that. Yep.
My husband also goes to Dr. Zonder and he had the Evusheld and no side effects, no issues at all.
right.
Smooth. Mhm.
Yeah.
So
Did
there's
you
a-
get, was the dose large enough? Because they started off with a smaller dose. I had to go back for two more shots.
I think he
I
had
went back for 2 more as well.
yeah, I
Okay.
think he had a couple. Mhm.
Yeah, I got it early
They
and I
felt
got
the
100.
initial dose wasn't large enough.
Right.
They felt the initial dose was not large enough.
Mhm.
Yeah, they initially gave me 150 milligram shots, and then FDA came out and recommended 300 milligrams. So I had to get another 150 milligram shots.
So
Gosh,
what was
I'm
the
so
period of
impressed by
time-
your knowledge.
Yeah, I was going to make an appointment. Mhm.
So I'm
there's a-
curious, what
oh, go
was
ahead.
the period of time between the 2 Evusheld shots?
Couple weeks.
Couple weeks? Okay.
Then I had to go back for two more, but
I'd
Okay.
say my period was about 2 months. But the information for the extra shots came out maybe in the middle of that.
So it sounds like Hale and Alan go to Dr. Zonder as well. Is there any other Dr. Zonder patients? Judy? Hmm. Just interesting to know. I'm sure my husband's probably ran into you guys from time to time.
It's my husband, not me, but yeah.
Oh,
he goes
okay.
Under, yep. He sees him in Farmington Hills, so that might be.
Oh, okay. My husband goes to the Detroit location because he's also on a clinical trial that they have to monitor there.
Mhm. Yeah. So I do have a question. Is
Speaking of
anyone
monitoring,
else-
Sorry. Who said they have a
Okay.
question? Was that Betsy? Or
I did.
I was just going to mention a
Has
brief
it-
thing about clonoSEQ, but let the patient talk.
okay.
Oh, just wondering if anyone else here has had CAR T done.
I have.
How has your response been?
Well, they put me in a complete remission in January. I did really good in February. And then in March, I had a spot on my PET scan on my femur. So I made it a year.
Okay.
Are
you
it's only,
you
it's only,
considered
it's only
high
the one
risk?
spot.
Are you considered high risk?
No, well, I might be now. I had a stem cell transplant that lasted 9.5 years. And I relapsed
Wow.
2 years ago, and we've just been having trouble now. I mean, this was my third shot at something. So they call it a controlled relapse because it's so little right now. I don't have measurable disease, but they're going to probably do radiation. I met with my local oncologist yesterday. I'm in a trial at Roswell, and they're going to probably add Polymist and Selexinor. Is that what it's called? They don't want to do anything drastic like another stem cell transplant, even though they have my stem cells, because there's, very likely still good T cells in there trying to do their job. And if they do that, they'll kill them as well. So disappointing.
My husband just finished 2 months of selinexor
Mm-hmm.
with filzimab.
Mm-hmm.
It did not do much. This is post CAR T failure. The selinexor is a pretty nasty drug. So I wish you all the best with that.
Oh, geez. Okay.
Just giving you a heads up. Giving you a heads up. And it works for many people. It just did not work for him. So we're at a point where we've got very few options left. So that's why I asked the question, because he's high risk and has tried pretty much everything on the market. So if anybody's got something out there that we haven't tried, let me know.
Well, it looks like we now have Dr. Margolis.
Oh, good.
So-
Yay.
I apologize for being late. That sounds like you guys have kept things going without me.
We have.
Good morning.
Morning. So Dr. Margolis, why don't you just kind of start by maybe giving a little introduction of yourself for those people that are new here. And then we can take questions. We've got some questions in the chat, and then we have some that were given to me beforehand too.
Okay. Hi, I'm Jeff Margolis. I'm a practicing medical oncologist. I'm the president of Michigan Healthcare Professionals, and I have an expertise in multiple myeloma. I'm a frequent person on this chat and enjoy having breakfast with you guys, and can't wait to eventually do this in person.
So do you want to, can you see the chat? I don't know if you can or not, Dr. Margolis.
I can see pictures like Hollywood squares.
Yeah, right. Do you want me to read these questions, or do you want to, or can you see them and read them yourself? I'm not sure.
Want to read them? I'm happy to start to go out.
Okay, this is from Jerry Oth. In your experience, does Polymus have a greater risk of blood thickening than Revlimid?
Yeah, no, probably Revlimid's got a little bit higher risk of blood clots than Pomalyst, but again, with appropriate prophylaxis, both agents can be very easily managed. And for most patients who are, would consider low to moderate risk, aspirin is plenty. And for patients who are, at high risk, then using anticoagulants like Lovenox or some of the drugs like Eliquis or Xarelto work just fine.
Yeah, that's what I'm on, is Eliquis.
Yeah, Eliquis works very, very well.
So Hal asked this question. Should we continue to get COVID booster shots every 6 months?
Yeah, so that's an ongoing question. And part of it is the shots right now are in response to the what the virus is actually doing. And so we can't think of this as one virus or one thing. It's moving like the flu. And just like every year, you have to get flu shots, we may have to adapt to what's going on with the virus. And as the virus has had variations, what we found is that our antibodies have gotten lower. And when they're lower, people may not have the same protection. So we'll continue to follow what happens with the virus, and we may have to have additional boosters. There may be additional vaccines coming that are variant-specific vaccines, but it will be in response to what's going on in the community and in the world with the virus. Unfortunately, for many people with myeloma, even with the vaccines, they're not getting the kind of protection that we want, because the myeloma itself prevents people from making good, meaningful antibodies. And a lot of the drugs that we're taking prevent people. So fortunately for patients with myeloma, there's now a new called Evusheld. And Evusheld is basically pre-made antibody against COVID. And so for people with myeloma, we recommend that if you're on treatment for myeloma, that you get treatment with Evusheld. And this is a shot that you get once every 6 months, and it's pre-made COVID antibodies, and it appears to be very protective.
Jerry Oth said this: 4 days after getting Evusheld, I contracted RSV. The PCR test showed negative for COVID. Do you think that was coincidental? It took me 6 weeks to overcome the symptoms of the RSV.
Yeah, so those are unrelated. When you got Evusheld, Evusheld is a pre-made antibody, and RSV is a virus, and the two things aren't related. Unfortunately, the Evusheld is only an antibody against COVID, so it doesn't protect against anything else. Some people with myeloma are getting a broad amount of antibodies called IVIG. And when people get IVIG, there can be protection against a wide variety of viruses. Unfortunately, there's not enough COVID antibodies in IVIG to be protective against COVID.
Let's see. You know, if anyone has a question that they want to just blurt out, since we've all been talking, you can do that too. I have a few more questions that were given to me in advance. I can read those right now. But please just use this time too to just ask your questions. I've got one from Judy Trudeau. It's her husband Joe is the one that has multiple myeloma, and her question is: Joe is at a point in this disease where he's failed the CART. We enjoyed 17 months with no treatment, and now we are seeking the next best treatment. I know this is a general question, so Dr. Margolis may not be able to answer this, but she's just looking for some, some suggestions, I guess.
Yeah. So again, this is the type of time when you need to sit down with your doctor and start to review kind of what your goals of care are, and then to look at what treatments you've had and what have worked. So sometimes if you kind of map out, and since people with myeloma have been on a long journey, sometimes even the oncologist that's practicing forget what you've been on. And sometimes you can go back and reuse some of the treatments that have worked in the past. So if all of a sudden, it was 5 years ago and you were on Velcade, Revlimid, and dexamethasone, you may be able to go back to Velcade, Revlimid, dexamethasone. It's combinations of the drugs that we have available, and then kind of remixing and matching them. In addition, clinical trials is a very active and important part of myeloma. And if you haven't been participating in the Myeloma Research Foundation, they've got the cloud technology where we can sequence your myeloma. And based on some of the sequencing in the myeloma itself, we can help try to predict what treatments may work.
This question is in the chat from George Chen. Are myeloma patients cured in remission with MRD negative over 2 or 5 or 10 years or longer under your algorithms? When we stop maintenance and chemotherapy with MRD negative, not exact. And then it goes on. Is it possible to have liquid bioplesis from regular blood or serum to find myeloma markers such as NGS or NGF with liquid biopsies by using mass spectrum during myeloma treatments?
Yeah. So whether we're actually curing myeloma patients now or not, we don't know. What we do know is that there are some patients with the current treatments that we're getting that get in very deep remissions, and they have, molecular responses and have no disease. The hope is those patients are cured, but we just don't know. We've got to follow people out for 10, 15, years and see. But we're certainly seeing some patients that have very prolonged remissions. What we're trying to do now is not have to do so many bone marrow biopsies. So in the past, when we were looking at people's myeloma cells, we always did those wonderful bone marrow biopsies that all the patients on here love so much. And then on those bone marrow biopsies, we would do molecular testing, and we would do things to look to see if you have myeloma. What we found over the last couple of years is that when you have myeloma, or for that part, any kind of cancer, a lot of the abnormal DNA from the cells leak out into the blood. And that's what's called a liquid biopsy. And we are now starting to do liquid biopsies on people with solid tumors, lung cancer, things that aren't even supposed to be in the blood, as well as in myeloma. So yeah, we can do liquid to see if there are molecular markers that could require treatment without doing the bone marrow. The other thing that people are using liquid biopsies for, and this is really kind of a very growing field, is to be able to monitor using liquid type biopsies to see if people are relapsing. So theoretically, if you have no myeloma in your body, you've got no myeloma gene, and you have no protein, everything's good. Another way you might be able to follow people is by doing liquid biopsies and starting to see if these myeloma genes start appearing again in your blood.
Okay, let's see what we have here. Okay, this is something that Hal was speaking about a little while ago. It's a question that he gave me beforehand. Why doesn't the therapy we have for myeloma, for example, Palmist, protect us from other cancers like prostate cancer?
Sure. So the each cancer has its own set of genes within the cancer that get mutated and cause those cells to grow. And different cancers are sensitive to different drugs because they have different mutations that are in there. In fact, what we're finding is even cancers that we used to think of as all the same. Pick on lung cancer for a second. Those cancers actually have specific mutations where one lung cancer will respond to one pill, another lung cancer will respond to another pill, another lung cancer will respond to another pill because they've got different mutations. The whole idea in myeloma now is to try to start to separate people into different categories where the myelomas are all different. So right now we know that there are some myelomas that are higher risk. So you have a deletion 17 or a P53 mutation. We know those myelomas tend to be more aggressive. Well, the idea is eventually to say, okay, well, if you have a P53 mutation in your myeloma, maybe there's a specific drug that we can use to target that kind of myeloma that will work for people that have those mutations. And so kind of going back to your original, is Pomalyst has got a lot of activity in hematologic cancers, but it does have a activity in solid tumors.
Uh-oh.
I'm here.
Okay. Okay. Here's a question from Cynthia Lee. What do you recommend for timing between Evusheld and booster shots for COVID?
So the best thing to do is to get your booster shots and everything before you get your Evusheld. Once you get your Evusheld, it's unclear if the booster shot actually works. There's no harm in trying. We recommend that you continue to do it. But theoretically, when you get a vaccine, your body is seeing an antigen, and that antigen is promoting an antibody response. If you've got a lot of Evusheld around, as that antigen comes in, the Evusheld may actually mop up and clean up that antigen so you can't respond to the vaccine. So our preference is you get the booster before your dose of Evusheld, but if you already got the Evusheld, it doesn't hurt to do it.
Let's see.
I had one booster and then I started the Evusheld.
So you've had three.
I had 3 vaccination type shots and then I started Evusheld.
You know, you're probably adequately protected with what you've got. It certainly won't hurt you to get the 4th. I usually tell people to get the 4th, but I think the fact that you've got the Evusheld right now, you should feel pretty good about things.
Yeah.
Can I ask a question?
Sure.
Right before you came on, I kind of got this bejesus scared out of me by someone saying that selinexor was a really nasty drug and well, not very effective in their case. I'm supposed to be starting on that. What kind of side effects are common with selinexor?
Yeah, you know, most people do okay with it. People can have, you know, fatigue. I've had people get with it, diarrhea. And like every drug, it depends on the shape that you're in when you're taking it. And it's also about adjusting the doses to make things tolerable. So we don't ever have people just suffering on the drug. So it's mainly about, as you start to get side effects, is to give communication to your doctor so they can adjust things.
Okay.
And again, if you give medications to people who are very, very sick and they've failed a lot of treatments, they don't do as well with it as people who are doing, you know, well and feeling good to begin with.
Yeah, well, I just had what they call the controlled relapse. I had a CAR T a year ago and I have one tiny spot on my femur. So they wanted to perhaps do radiation and start me on Pomalyst and Dexin and selinexor to sort of jump all over it.
Yeah, I think that's a very reasonable thing. And again, just like everything else you've gone through, if you read the package insert or you look about CAR T, that's supposed to be horrible. But for most people, it's manageable.
Okay. Thank you.
You're welcome.
Okay, let's see. Anybody else want to just speak out here? I've got a question from Mary Norat from before. If a person has multiple increased or decreased LGS, in parentheses, LGG, LGA, or LGM during MGUS, does that equate to them being more likely to go on to increased risk of disease progression?
So I think what the person's asking is when people have MGUS, one of the things that you can have with MGUS is reciprocal changes, meaning that if your abnormal protein is IgG, your IgA and IgM can be lower. And when you look at MGUS, that is a small risk factor for progressing on to myeloma. The bigger risk factors for progressing on to myeloma is what percentage of plasma cells do you have in your bone marrow? How high is your M spike? How high is your free, light chain? Are there cytogenetic abnormalities that are there? And there are some people who have high risk MGUS, but again, for the vast majority of people with MGUS, the chances of progressing on to myeloma is still very small. It's about 1% per year.
So George Chen put something else in the chat here. My spouse has carried multiple on pancreas and pelvis and collected her stem cells after cocktail chemotherapy without stem cell transplant since 2011. Is it possible to transplant if she needs it? How does she to prevent GVHD if she has a transplant?
So when we look at transplant, we're taking stem cells out of somebody and we're putting them in a freezer. And it turns out that those stem cells can survive in the freezer for over a decade. So long as the stem cells are kept in an appropriate freezer, they don't really have that kind of a shelf life that they've expired and you can't use them. The biggest problem with doing that is you have to find a place that will actually store the stem cells. Most of the places will charge you after a period of time to continue to store the stem cells. Many of the centers that do transplants, they have to have some amount of freezer space. And so they're not, willing to store the stem cells indefinitely. And so you need to find some secondary places to store them. I don't have an address on the tip of my fingers, but afterwards, if someone needs places to store it, we can get you some places like that. Graft versus host disease is a disorder that occurs when you get a stem cell transplant from somebody else. So for most people who have myeloma, you're doing an autologous transplant. That's a transplant from your own body. And in that situation, there is no graft versus host disease. In people with stem cell transplants from another person, sometimes those stem cells see the other person as the enemy, and the stem cells reject the person. Just like someone gets a solid tumor graft, you put a kidney in, you've heard about someone having the body reject the kidney. Well, in this case, the stem cells get put in and they see the person as the enemy and they get a reaction. And that's called graft versus host disease. And in myeloma, there's pretty severe graft versus host disease. And that's why only under very, very unusual circumstances do we do allogeneic transplants in myeloma, because how versus host. When we do allogeneic transplants, in order to prevent graft versus host disease, we use a lot of very powerful immunosuppressive drugs, just like when people get kidney transplants or liver transplants to prevent rejection. So most people who are getting a transplant for an allogeneic transplant are on a drug like tacrolimus. They'll be on some prednisone. Sometimes they're on a drug called Cellcept, but they're on multiple drugs that kind of suppress the immune system to prevent this graft versus host disease.
So this came in on my emails from Gordon Bellis, and it's kind of along the same lines as what you just answered. You probably just answered most of this, but he'd like you to please explain, please give an opinion for bone marrow transplant, which is kind of a broad
One
topic.
more question.
Okay, could you please ask for opinion on bone marrow transplant?
Sure. So when people had looked at multiple myeloma, and you go back to the early 80s, we didn't have very good drugs. And in those days, there was a drug combination we don't use very much now called VAD. And what happened is you took drugs that weren't very good and you flipped a coin, and you either got a stem cell transplant or you continued to get VAD. And clearly what happened with the stem cell transplant in that situation is that we improved outcomes by doing stem cell transplant. So stem cell transplant became the standard of care. As time had progressed, we started looking at some of the combinations that most of you have. When we look at those combinations,
Oh, we're losing you. Uh-oh.
hello?
Hello?
No, am I here?
No, I think you just dropped off totally.
Hey, Mickey, I think if you mute everybody else,
I can hear him.
it'll stop cutting out the doctor when he's talking.
Yeah, I'll try doing that, but I think we just lost him totally. I'm admitting him again. He dropped out. I will mute.
There we go.
everybody.
All right. Am I back?
You
You're
are
back.
back.
Okay. So when people looked at these early studies, it was very clear that stem cell transplant was the way to go. Well, as the treatment started getting better and better, we started looking at treatments without stem cell transplant. And if you look, historically, the drugs that we gave were as good as stem cell transplant. So we can achieve with just plain old medications the same results as we can with stem cell transplant. So people then asked a question, if you take good drugs and then you do a stem cell transplant on top of that, do we get better outcomes? And a study that looked at patients who were under the age of 65, they looked at people who were treated with RVD, and they randomized them, again, flipping a coin to just doing RVD or continuing stem cell transplants. And once again, there was an improvement with stem cell transplant. So what fuels the fight now about stem cell transplant is, do you still need stem cell transplant with all the other great drugs that we have, together? And the answer is no one really knows, because the drugs have gotten so much better. You're getting results that you would see just like people were to get stem cell transplants. But at least our current thought is that if you've got really good treatment and you take really good treatment and you pair it with a stem cell transplant, things should do better. So for most patients with myeloma, we at least offer them a stem cell transplant, and we talk to people about stem cell transplant because I still think it's an important part of myeloma. I think over the coming years, it may be that we'll take what we now use for late myeloma and do CAR T, and we move CAR T cell earlier and don't do stem cell transplants. We reserve stem cell transplants for only people who have high risk, myeloma, and kind of mix and match some of these things. But right now, it's still an important part of treatment for myeloma, and it's something that you need to talk to your doctor about.
So what I did is I went in and muted all of you just so that we don't have any background noise. But if you want to speak, just unmute yourself. You're able to do that. And I do have a question here from Cynthia Lee. Would I or my MD be notified if the storage place wants to discard my stem cells?
They should, and depending on the contract that you signed, they should give you a notification. But it's important that you look at the contract you sign and the viability of some of these places. Not all these places, when this all started, no one thought that we were going to be storing stem cells for a decade or more. And just like any other business, some of these businesses change hands, they get renamed. It's sometimes hard to find who the business is. So you just have to, keep checking up on it like any other valuable.
This is a real interesting one from Hal. Is there any research going on with umbilical cord blood from the birth of a grandchild to transplant myeloma patients?
Yeah, so cord blood has been used to do stem cell transplants, and cord blood is just like an allogeneic transplant. It's taking a transplant from somebody else, and when you do that, you run the risk of graft versus host disease. So for other diseases where we do a lot of allogeneic transplant, people absolutely do use cord blood. The problem with cord blood is that if you the amount of stem cells in the cord is small. So if you're a small person, then there's sometimes enough stem cells to use in cord blood. If you're a larger person, sometimes there's not enough stem cells to use. If it's a grandchild that you're looking at stem cells, then they're not going to be a real close match to what you are, because they're going to have other DNA. So typically, you want to use, cord blood from someone that's a match to you. So we actually have a bank where some people take their cord blood and they donate it, and then we can look in a registry to see if you're a match to cord blood that's in the bank.
It's really interesting. Here's a question from George. What is the difference between multiple myeloma and extramedullary plasmacytoma?
Sure, great question. So in people who have myeloma, you've got plasma cells that invade your bone marrow, and then these lesions that you talk about in your bone are lytic bone lesions, and they're full of these abnormal plasma cells, which is what the cancer is. There are a group of patients who will just get a single spot that's got a cluster of plasma cells in it. And there's really two types of plasmacytomas that people will see. Sometimes people will get in their soft tissues or in their sinuses. And when you look at those patients and you work them up, you do PET scans, you do bone marrows, you do everything, you can't find any other place where there's any myeloma cells. And usually with those patients, if you give radiation treatment to that plasmacytoma, 2/3 of those patients are cured, 1/3 of them become myeloma. If you look at people who have plasmacytomas that are in their bone, so the only place they have it is in their bone, you do a workup of a PET scan, a bone marrow, you don't find anything, and you do radiation to the plasmacytoma in the bone. In that situation, about 2/3 of the people end up with myeloma, and 1/3 of the people end up being cured. So in some patients, a plasmacytoma is just an early sign of multiple myeloma. You haven't developed the myeloma in other places. And in some patients, the plasmacytoma is the only site of disease, which is why it's curable with radiation.
So I ran out of questions here, but please just unmute and ask a question or put it in the chat. We just have a few more minutes left here. So please just feel free to use this time to ask anything that you want.
When you're in treatment for myeloma and you're taking ELO as an infusion and Dex once a month and Pomalyst 21 days, what would you take off when your numbers go down enough for maintenance? Would you take off the ELO or the POM, or do something completely different?
And we're meant to continue to take them, but everyone's done so tremendously, well with this, that we start to take these things off to do maintenance. What I typically try to do is get rid of the infusions first, just because they're, inconvenient, and then continue with the orals. And then we usually have a conversation. And when I talk to most of the patients, the next step, if we're going to do more maintenance, is no one seems to like the Dex very much. So we start to drop the Dex, and usually we'll, instead of doing the Dex once a week, then we're doing it every other week, and we're kind of stretching the thing out. And then if people's proteins start going back up, then we start to add the Dex back in and start to kind of re-escalate the treatment. But I think that's where there's really kind of an art to this and how you kind of customize things.
Thank you. Because the blood clotting, my husband's on Lovenox, because with Revlimid, he had pulmonary embolisms, and so the aspirin was not enough, but now he's on POM, and I don't know if they've kept him on Lovenox just because of that. I don't know if that's something that will go away with certain meds when they go away or what.
So, typically, if you're still taking drugs like Revlimid or almost any of the IMIDs, I would usually recommend continuing anticoagulation. I think the option would be to continue the Lovenox. It works very well. The downside with Lovenox is that it's an injection that you have to give yourself. So for some patients, it's just more convenient to use our DOACs, which are like Xarelto or Eliquis, and those are oral medication, just a little bit easier to do. Some people have actually even used Coumadin, which is an oral medicine, but requires a lot of monitoring. So I find myself usually using a lot of the DOACs and use a lot of Eliquis or Xarelto. But Lovenox is really the kind of the gold standard for things.
Thank you, because my husband's had to have an appendectomy and a couple cataract surgeries and a cancer unrelated to myeloma on his cheek that's supposedly gone. And the Lovenox is really simple to stop and start, right, compared to the oral ones.
So Coumadin was a big reason that most of us don't use Coumadin anymore. Is that was a problem. You had to stop it for 5 days. The DOACs, the Xareltos, and the Eliquis, you have to stop 2 days before surgery. The Lovenox, you have to stop a day before surgery. So there's a little bit more flexibility with those. So again, that's why most people don't use Coumadin, and I think it's either going to be using a DOAC or a low molecular weight heparin.
Okay, is there one particular oral that's better than another?
No, I mean, they all market do it. Xarelto's once a day, Eliquis is twice a day. If that body, how often you take a pill, maybe one's better. Most of the time when we use Lovenox, it's the most popular of the low molecular weight heparins, but it's not sure it's any better than Fragment or any of the other low molecular weight heparins.
Thank you so much.
You're welcome.
Well, we're right at the 8 o'clock hour. Does anybody have any last minute questions for Dr. Margolis before we let him go?
I just wondered if Pomalyst is anti-angiogenic, like thalidomide was. That was the basis for my earlier question about getting other cancers, solid tumors.
Yeah. So thalidomide, Revlimid, and Pomalyst do have some angiogenic properties, and that's part of the way they work. What we have found is anti-angiogenesis properties themselves have not been adequate to treat cancers, and that's why it doesn't work for prostate cancer. So even drugs that are completely angiogenesis, like Avastin or bevacizumab, they don't have any effect on prostate cancer. Angiogenesis is changing the way the host responds to the tumor. So it's preventing the cancer from getting new blood vessels. And by getting new blood vessels, you strip the cancer of its supply. So the angiogenic properties are important and add to it. But one of the other things that happens with actually thalidomide, Revlimid, and Pomalyst is they're also immunomodulatory drugs, and they actually help the immune system attack the cancer. And that's why they're such important drugs in myeloma and in hematopoietic malignancies.
Okay. Any last minute questions that before we go? It looks like some people are dropping off right now because they probably have to get going. So anything else that we've got going?
Thank you, Dr. Margolis.
Well, again, being late. So if there's other questions, I'm happy to stay late to answer.
Okay.
Thank you.
Also, if people want to just send me questions, if you've got any more to continue this conversation, I can always send them on to Dr. Margolis.
Dr. Margolis, is there a particular timeline for myeloma? I had read, all different times of it impacting your life, how it shortens it. Is there anything overall, or is it also individual?
It really becomes individual. Not one person on this phone call is a statistic, and everybody is different. Every myeloma is different. That's why we're doing this this cloud technology in sequencing the myelomas. That's why almost every one of you have had FISH testing in cytogenetics, because some myelomas are at higher risk than other myelomas. So if you imagine some people have what we'll call bad myeloma and some people have good myeloma, and you mix those two things together in those studies, that's how you get that average kind of number. We also know that there are things that you can do to help predict how well you're going to do with myeloma. So if you're someone that responds, you're going to do much better than people who don't respond. And there are people who respond, and when they respond, they stay in remission for years and years. Well, when those people relapse, they're almost certainly going to respond very well again and stay in remission for years and years. If you have a myeloma that, you know, you're going on treatment and it works for a month and it stops working, and you go on another treatment and it works for, you know, 6 weeks or 8 weeks, those are myelomas that tend to be more aggressive, and you need to think a little bit more outside the box on how you're going to treat those.
Okay.
Any other questions?
Well, I guess then it's 8:04. We've done our hour, and I thank you everyone for getting up and joining this conversation. It's been very interesting, especially just chatting amongst each other was kind of nice too. So thank you, Dr. Margolis, for taking this time, and thanks everybody else for getting up early. So again, if you have any questions, you can always send me an email or to Molly pretty soon, and we will take it from there. So have a great day, everyone, and guess I'm going to end this now. So
terrific.
Thank you.
Thank you. Thank you, Doc.
You're welcome. Bye-bye.
Thanks.
Bye.
Thank you.